Now that we've discussed nephron physiology, it's a good time to take a look at the renal tubular defects. The eponyms can be hard to remember, but I like the following mnemonic because it helps you remember the order of the syndromes along the nephron. It is, the kidneys put out fabulous glittering liquids. The F in fabulous is for Fanconi syndrome, which is a reabsorption defect in the proximal convoluted tubule. In Fanconi syndrome, the cells of the proximal tubule are non-functional, which causes all transporters to be affected rather than an isolated transporter defect. Now that we've covered some of the renal phys already, can you guess what might be lost in the urine if the PCT doesn't absorb any solutes? Correct, glucose and amino acids. Bicarb and phosphate will be lost as well. There are a handful of causes, some of which are hereditary, such as Wilson's disease, and others are non-hereditary, like ischemia or nephrotoxic drugs and chemicals. Barter's syndrome is a reabsorption defect in the thick ascending loop of Henle. It is an autosomal recessive mutation of the sodium-potassium 2-chloride cotransporter. It results in hypokalemia and metabolic alkalosis, similar to what you would see with the use of which diuretic? Correct, a loop diuretic. Gittleman syndrome is a reabsorption defect in the distal tubule due to an autosomal recessive mutation in the sodium chloride cotransporter. A deficiency in this cotransporter would be similar to the use of which diuretic? Good, thiazides. It is less severe than Bartter syndrome. And why do you think that is? Well, because the majority of sodium reabsorption occurs in the earlier parts of the nephron. Little syndrome results in an increased reabsorption of sodium in the distal and collecting tubules. This is due to increased activity of the epithelial sodium channel. It is autosomal dominant and results in hypertension. It causes decreased aldosterone levels due to the negative feedback inhibition from the hypertension. Treatment for Little syndrome is amiloride, which blocks the overactive sodium channel. The syndrome of apparent mineralocorticoid excess is a hereditary deficiency of 11-beta-hydroxysteroid dehydrogenase, which normally converts cortisol into cortisone in cortisol-sensitive cells. The syndrome of apparent mineralocorticoid excess is a hereditary deficiency of 11-beta-hydroxysteroid dehydrogenase, which normally converts cortisol into cortisone in cortisol-sensitive cells. If this enzyme is absent, excess cortisol will activate mineralocorticoid receptors, resulting in hypertension, hypokalemia, and metabolic alkalosis. Interestingly enough, this can be an acquired disorder if you eat too much licorice, which blocks the enzyme's activity. Now, step 1 probably won't be interested in having you memorize the exact genetics of these disorders, but it will be interested in testing you on the signs and symptoms of the patients with these conditions, such as hypokalemia in Bartter syndrome or hypertension in Little syndrome. Let's move on to see how solute concentration changes along the proximal tubule. On this graph, the x-axis is the percent distance along the proximal tubule, and the y-axis is the ratio of tubular fluid concentration to plasma concentration. If we look at the concentration of inulin along the proximal tubule, it will make a straight line from 1 to 3 because it's freely filtered and neither secreted nor reabsorbed. The concentration is increasing along the proximal tubule because water is being reabsorbed. The area below inulin includes all substances that have net reabsorption. The area above inulin includes all substances that have net secretion. There are a couple important points to take away from here. First, the vast majority of substances have net reabsorption in the proximal tubule. This includes urea, ions like chloride, potassium, sodium, inorganic phosphate, bicarb, and molecules like amino acids and glucose. Generally speaking, where along the nephron will most of this reabsorption take place? Well, in the proximal tubule. Second, the tubular fluid to plasma ratio can tell you how quickly something is being absorbed relative to water. For example, glucose and amino acids are reabsorbed very quickly in the proximal tubule and much faster than water, so they are completely reabsorbed by the end of the proximal tubule. On the other hand, chloride is reabsorbed slower than water in the proximal tubule, which makes sense since there are other anions such as phosphate and bicarb that are also being reabsorbed. Molecules like creatinine and PAH are secreted, so their TF over P ratio is above that of inulin. The concepts behind this graph are high yield in the exam, and if you understand how the proximal tubule works, you shouldn't have any trouble filling things in. For example, why does the line for inulin increase steadily over the course of the proximal tubule? Well, since inulin is freely filtered but not reabsorbed, the amount of inulin in the tubule remains constant, but water is progressively being reabsorbed with sodium. so that concentration of inulin gradually increases from the beginning to end. Again, use this graph as a reference during your studying. Now let's discuss how the kidney regulates blood pressure. This is one of the most important roles of the kidney, and it's done using the renin-angiotensin-aldosterone system, also known as RAS. Note the order of the hormones, renin, angiotensin, and aldosterone. This is also the order of the pathway. Since the kidney is trying to maintain blood pressure at a normal range, any deviation from this range will cause a change in RAS. Do you know any stimuli that will cause release of renin into circulation? A decrease in blood pressure, reduced delivery of sodium to the macula densa cells in the distal tubule, or an increased sympathetic tone. These will all lead to the release of renin from the juxtaglomerular cells. And where again are these JG cells located? Well, these are modified smooth muscle cells that are found in the afferent arteriole. All three of these changes will occur in a state of low blood pressure, such as blood loss or severe diarrhea. Now, renin is an enzyme which converts angiotensin produced by the liver into angiotensin 1. Angiotensin 1 is then converted into angiotensin 2 by ACE in the lungs. Angiotensin 2 has a number of effects to increase blood pressure. It stimulates general vasoconstriction as well as constriction of the efferent arteriole in order to maintain the GFR. It stimulates the release of aldosterone from the adrenal gland, which goes on to stimulate the reabsorption of sodium and therefore water in the collecting tubules. Angiotensin 2 stimulates the release of antidiuretic hormone from the posterior pituitary. This allows for water to be reabsorbed through the aquaporin channels in the collecting tubule. Now quickly, do you remember the receptor that ADH binds to in the principal cell membrane? Correct, the V2 receptor. Finally, angiotensin 2 stimulates the reabsorption of sodium in the proximal tubule, which will bring water with it. There are a handful of ways in which angiotensin 2 increases blood pressure. That's why taking a drug like enalapril, which is an ACE inhibitor, is such an effective way to lower the blood pressure because it renders these angiotensin-mediated pathways less effective. Another important hormone to know is atrial natriuretic peptide, also known as ANP. This hormone works against RAS. Do you know what causes the release of ANP into circulation? Stretching of the cardiac atria due to increased blood volume. Can you think of a cardiac pathology that might result in an increased ANP secretion? Well, mitral stenosis. If blood can't be pumped into the ventricle, it will fill up in the atrium and cause subsequent myocardial stretching. This will be seen in much more detail in the cardiology section. But the actual function of ANP is to relax vascular smooth muscle in an effort to lower the blood pressure. It also increases the GFR by dilating the afferent arteriole. This allows blood to continue to be filtered while reducing the blood pressure. ANP also decreases renin release, again to reduce the blood pressure. Knowing the inhibitors for important pathways will be key for the exam. RAS is a very important pathway, especially with the high prevalence of hypertension, so knowing the pathway as well as its inhibitors, such as ANP, will be important for your exam as well as your clinical practice. Let's briefly talk about the juxtaglomerular apparatus. This collection of cells serves as a sensor and feedback system to maintain blood pressure. The macula densa cells detect the concentration of sodium in the filtrate in the distal tubule, and the JG cells sense the blood pressure in the afferent arteriole. Reduced blood pressure will lead to a reduced sodium delivery to the distal tubule, so both the JG cells and the macula densa cells are ultimately detecting the blood pressure of the body. So it makes sense that the juxtaglomerular apparatus will release renin when the macula densa cells and the JG cells are stimulated by low blood pressure and/or a decrease in sodium level in the filtrate. The macula densa cells can directly stimulate the JG cells to release renin. The JG cells are modified smooth muscle cells in the afferent arteriole. So in which layer of the arteriole are they found in? Well, they're found in the tunica media with the other smooth muscle cells. Flash quiz. The sodium concentration along the length of the proximal tubule remains constant, which means it has net reabsorption, net secretion, or neither. There will be net reabsorption. Let's take a look back at our graph of relative concentrations along the proximal tubule. Note that the TF to P ratio of sodium is very close to 1, and it's in the purple region, which means it's being reabsorbed. This means that the sodium concentration along the length of the proximal tubule remains constant, because water will move isoosmotically with sodium. Don't get confused by thinking that a TF to P ratio higher than 1 means secretion, and a TF to P ratio lower than 1 means reabsorption. This is wrong. In order to be secreted, a substance must have a TF to P ratio that is higher than inulin. Anything with a TF to P ratio lower than inulin will be reabsorbed. Now let's move on to an important function of the kidney that students often forget about, the hormones. There are 4 important hormones secreted by the kidney. 3 of them are endocrine hormones, meaning that they act where? At distant sites. And the 4th is a paracrine hormone, meaning that it acts locally. The first is erythropoietin. When the kidneys sense hypoxia, the interstitial fibroblasts near the peritubular capillaries release EPO into the bloodstream. EPO then goes to the bone marrow, which then stimulates the production of more red blood cells. This is a very relevant fact for your exam, since this process can be significantly altered in the context of a renal cell carcinoma. We'll go into more detail about these cancers later on, but just to give you a heads up, they can secrete EPO in an uncontrolled way even if there's no hypoxia present. So one of the first ways you can detect this cancer is by an elevated hematocrit. What is it called when you have too many red blood cells? Well, the name for this is polycythemia. It can be appropriate, as in a response to hypoxia, or inappropriate, as in a response to excess, uncontrolled EPO production. Can you think of any other condition that might stimulate an increase in EPO secretion? COPD. This is a very common disease that is often tested on and is often seen in clinical practice. These patients are in somewhat of a chronic hypoxic state, so their EPO levels tend to be increased. When this happens, we call it secondary polycythemia. The next important renal hormone is activated vitamin D. Inactivated vitamin D is synthesized in the skin or can be ingested, but the kidney and liver are needed to convert it to an active form. First, 25-alpha-hydroxylase in the liver has to convert vitamin D to 25-hydroxyvitamin D before the kidneys can convert it to 1,25-hydroxyvitamin D. Do you remember the enzyme that's responsible for this last conversion? It's 1-alpha-hydroxylase. And where is this enzyme produced? In the proximal convoluted tubule. In the kidney, parathyroid hormone stimulates the production of 1,25-hydroxyvitamin D. Can you recall from the endocrine chapter what this will lead to? Well, 1,25-hydroxyvitamin D, or activated vitamin D, will increase the intestinal absorption of both calcium and phosphate. It also increases renal calcium reabsorption and decreases phosphate reabsorption. A clinically relevant note is that renal failure can lead to decreased production of vitamin D and subsequent bone problems. Do you know the term for this condition? Renal osteodystrophy. Next, we have a paracrine hormone, which belongs to a group of hormones called prostaglandins. This picture is an example of a prostaglandin, and they are synthesized from arachidonic acid. Like we said before, these act locally. Do you remember the roles prostaglandins have in terms of GFR and renal blood flow? Prostaglandins, specifically prostaglandin E2, vasodilates the afferent arterioles to increase GFR. Now, if NSAIDs inhibit prostaglandin synthesis, how might this affect a patient clinically? NSAIDs can lead to vasoconstriction of the afferent arterioles and subsequent acute or even chronic renal failure. The kidneys will not be able to properly filter the blood if the GFR is reduced. Constriction of the afferent arterioles can also cause papillary necrosis and chronic interstitial nephritis due to reduced blood flow. So remember, renal papillary necrosis is an often tested complication of chronic NSAID use. One more important function of the kidney, just so we can be comprehensive, is a function that you may remember from biochemistry. It's that the kidney can perform gluconeogenesis, converting lactate and glutamine into glucose.